Hello everyone, today's topic of discussion is anti-emetic drugs. Before knowing that, we have to know what does the word emetic means. It means vomiting. So before understanding this, we should understand why do have vomiting or the pathophysiology of vomiting. Vomiting center, which is located in the area posterior, is triggered due to which we get the reflex action as vomiting, or all the food inside the stomach gets reflexed outwards. So the various centers are chemoreceptor trigger zone, which lies outside the blood-brain barrier. Above on it, we have receptor like mu, CB1, NK, and CB1, NK1, 5-HT3D2. It receives signal from GIT blood vessels. Then we have nucleus tractus solitarius. The receptors present here are M, H1, NK1, 5-HT3, and D2. It receives signals from GIT. Then we have cerebellum. It has M and H1 receptor. It receives signal from the vestibular apparatus in the inner ear, which is also responsible for the roadway sickness, or what we say motion sickness. And then cortex, it is mostly psychological in nature, like when you sometimes see something or like a pungent smell, you smell a pungent smell, or you see someone vomiting, like that time some people tend to have vomiting. That's what is psychological in nature. We should understand the reason for vomiting. First is trigger a vomiting center. Here we use antiemetic drugs and then reduce gastric emptying. And is prokinetic drug. It is more of a digestive issue, which we will discuss in next lecture. A separate video to be made on prokinetic drugs. Then let's see the classification. It's from the Essentials of Pharmacology by KD latest edition. So, what are the medications? Like we know that some receptors are triggered, like cholinergic receptor M receptor is triggered, histamine receptor H1 receptor is triggered, B2 receptor is triggered, and 5-HT3 receptor is triggered. So obviously we will give its antagonists. Some anticholinergic, H1 antihistamine, neuroleptics or D2 antagonist, 5-HT3 and D2 antagonist, and 5-HT3 antagonist, prokinetic drugs, and NK1 receptor antagonist. So I will request you all to go through the names and remember it. At least the main one, like in prokinetic drugs, metoclopramide and domperidone, ondansetron, granisetron in 5-HT3, promethazine and diflucan H1 antihistamine. So please try to remember this by reading it again and again. That's the only solution in pharmacology, to remember the names of the drugs. Then, like, this is a very good way to remember everything, like all the key points, so that you can frame answer easily. So make a table with mechanism of action, pharmacokinetics, use, adverse effect, and contraindication, and dosage if you love to include it. So then you can compare and study. So let's start with anticholinergic. Anticholinergic, the mechanism of action is blockage of one receptor that blocks the nerve conduction to vestibular apparatus, and vomiting is suppressed. Its route is transdermal. 1.5 mg of hyoscine patch is given. You can write it in dosage for 3 days. It's used for motion sickness, morning sickness. In India, we give licyclomine. In adverse effect, it's short, sedation, and dry mouth, and other anticholinergic side effect. Then it's contraindicated in cases of gyrostomia or dry mouth in the patients who already have dry mouth. Then we have H1 antihistamine. It blocks the H1 receptor on cerebellum and NPS, and antiemetic action is seen. It's very much simple. Its usage is for motion sickness, chemotherapy-induced nausea, and vomiting. Like when people take chemo, they tend to have vomiting as a drug reaction. So we will give these people its antihistamine to suppress that. Its adverse effect is seen, sedation, dry mouth, and contraindication not much seen. Neuroleptics blocks the D2 receptor on CTZ and NTS. Antiemetic action is seen. It's given due to drug-induced post-op nausea and vomiting. After the operation, because of certain drugs, the patient tends to vomit. So we have to induce that, and same for chemo patients. It's reduced seduction, acute muscle dystonia, less effective in motion sickness. Yeah. NK1 antagonist blocks NK1 receptor in CTZ and NTS. It's metabolized by CYP3A4 and same for chemotherapy-induced nausea and vomiting and post-op. Most of the antiemetics are given for chemotherapy and post-op vomiting. It's weakness, side effect weakness, fatigue, and increase in liver enzyme. As you have seen, it is metabolized by CYP3A4 enzyme. Like it shouldn't be given to patients with Cisapride or Imazolide because it increases the QT prolongation. Then comes this lot of short notes on this, that is 5-HT3 antagonist. It blocks the emetogenic impulse both at peripheral and controlled relay to give anti-emetic action. Bioavailability of this drug is 60 to 70%, T-half is 3 to 5 hours, and duration of action is good, 8 to 12 hours. For cytotoxic drug-induced vomiting or generalized vomiting, we used. Most it gives adverse headache, dizziness, and abdominal discomfort. Contraindication not much. The main medicine we use in India is ondansetron. If you will see any antiemetic, you will see this composition is there must. If it doesn't work, then we give granusetron at tips for high doses. So I hope you all understood this chapter, at least for quick review or to understand the concept. This will help you